Hello dear students, in this video of simplifying OBG session we shall talk about Caesarean section. What are some of the questions which are asked to you in Caesarean section and what are the techniques of Caesarean section that you need to know. Basically lower segment Caesarean section which is done, let us first see the steps in very brief what we actually do. First of all we incise the skin. Now coming to the details of skin incision. How the skin incisions can be done? Skin incision can be a vertical midline skin incision, but nowadays the preferred modalities are to have a phenensteel or a horizontal skin incision. Now phenensteel skin incision, phenensteel, mind you the spelling of phenensteel, phenensteel, phenensteel incision is a smiling shaped incision which is given 2 centimeters or 2 fingers above the pubic symphysis. But if you give a horizontal incision instead of a smiling incision, a direct horizontal incision, then it is called the Joel-Cohen incision. Joel-Cohen incision. Joel-Cohen incision has very fast recovery rate and less pain because it is along the skin crease. So Joel-Cohen is also a preferred modality of skin incision that can be given. Number 2, if you consider vertical versus your horizontal incision, so which one is better? So the advantages of vertical incision is that it is a fast technique. Whenever you have to have a fast entry into the abdomen, you can go for a vertical midline incision and less chances of bleeding. There is less chances of bleeding because you are in the midline. But however, horizontal incision is best preferred because it is cosmetic. It is cosmetically better. Number 2, there is less pain with horizontal incision and faster recovery with this incision. Once you have incised the skin, then the second structure which you go through is subcutaneous fat. So subcutaneous fat is then separated and then followed by that you come to the anterior rectus sheath. So you go to the anterior rectus sheath and then you cut the anterior rectus sheath. Remember that above the umbilicus you have one anterior rectus sheath and a posterior rectus sheath behind and in front of the rectus abdominis muscle. But below the level of umbilicus you do not have posterior rectus sheath. So posterior rectus sheath ends in the form of linea semilunaris. Linea semilunaris is the ending point of posterior rectus sheath. So if you are giving a phenensteel incision or a horizontal incision, then you encounter the anterior rectus sheath. After that you separate the muscles. We generally do not cut the muscles. So the rectus muscles, both the rectus muscles are separated from one another. And then you do not have a posterior rectus sheath because it has ended at the level of linea semilunaris. So the next structure which you get is peritoneum. So parietal peritoneum. So you give incision over the parietal peritoneum and you go inside the peritoneal cavity. Inside the peritoneal cavity you get the uterus, and over the uterus there is the urinary bladder, the fold of the bladder. So you catch hold of the loose fold of peritoneum. Loose fold of peritoneum is caught hold of, and this peritoneum is cut. This is the visceral peritoneum or bladder fascia which is cut, and the bladder is retracted downwards. So the bladder goes down. So you now have only the uterus with the lower uterine segment. So we give a lower uterine segment horizontal incision which is also called the Kerr's incision. Okay, Kerr's incision is given in the lower uterine segment and then you deliver the baby. Once you have delivered the baby, then you give injection oxytocin. Management of third stage of labor is done and then the placenta and the after membranes are delivered. Once the third stage is over, then you suture the uterus and followed by then suture the peritoneum and approximate the muscles, suture the rectus sheath, anterior rectus sheath, and then suture the skin. So you go from in the reverse direction. Now let us talk about what questions really are asked and are important for your MCQs. Number one, what are the type of skin sutures, skin incisions I was telling? Pen and steel incision is the smiling incision which we were talking of. Then you have the Joel Cohen incision. Joel Cohen incision is a horizontal incision 2 fingers above the symphysis pubis. Okay, so this has very good healing capacity. Now coming to sutures, what sutures we generally use in Caesarean section? Okay, so the suture material most commonly used is your Vicryl suture. Vicryl is actually your polygalactine suture. Polygalactine 910 suture. Polygalactine 910 suture is a delayed absorbable suture. Delayed absorbable suture because it absorbs very slowly in the body. So this number 1 Vicryl suture, number 1 suture is utilized for suturing the uterus. Okay. Coming to the rectus sheath, the rectus sheath can be sutured with either Vicryl number 1 or you can use PDS sutures. PDS suture is polydioxone. Okay, dioxone is the PDS suture. It is a monofilament suture. Basically, it is a monofilament suture. And polyester suture. It is a polyester type of suture. Polydioxone is PDS suture. Otherwise, the rectus sheath can also be sutured with your Vicryl or polygalactine suture. Coming to skin. Skin sutures are generally sutured with non-absorbable sutures. If it is non-absorbable suture which is used, then you have to remove the sutures. So basically mattress suturing technique is utilized for suturing the skin, and the non-absorbable suture most commonly used is your nylon or ethylon, which comes under the brand name of ethylon 20 suture. Ethylon 20 suture or nylon suture is used. Then silk can also be used. This is also a non-absorbable suture, or proline can also be used, which is also a non-absorbable suture. Other than that, for cosmetic purpose nowadays, we can also use subcuticular sutures. Subcuticular sutures can be used. Now subcuticular sutures are sutures which are placed in the subcutaneous area so that the skin suture is not visible from above, and these will be absorbable sutures which are used. Absorbable sutures. So the most common and most cosmetic suture which is used is monocryl suture. It is monocryl suture number 10 or number 20 suture which is used. Monocryl suture is basically polyglycaperon suture which is used. Okay, so this suture is a bit costly, but it is very cosmetic. Regarding the sutures, let me tell you, suppose the number of the suture, if it is number 1, then number 2 is thicker than number 1, number 3 is even thicker, number 4 is even thicker. Coming to the thinner version, if we go from thicker to thinner to number 1 is number 0, then thinner to that is 0, 0, then 0, 0, 0, and then 0, 0, 0, 0. Okay, like this the suture number goes. So number 0 is also written as 10, 0, 0 is also written as 20, 0, 0, 0 is written as 30, and 0, 0, 0, 0 is 40. So it means number 2 suture is thicker than number 1. However, number 30 is thinner than number 20. So always remember this nomenclature which is used. Apart from that, one important technique I am going to teach you, and you should remember for your exam questions, is what is Misgav-Ladakh technique. Misgav-Ladakh technique of Caesarean section. This was first introduced in hospital in Misgav-Ladakh, which is actually in Jerusalem, where the first this technique was initiated. Misgav-Ladakh technique is a technique whereby blunt dissection is done. Blunt dissection. What do you mean by blunt dissection? Means we will do most of the dissection using our fingers. Finger dissection is done rather than using the knife and the scalpel. So what we actually do is first give an incision over the skin is incised, of course. After that, the subcutaneous fat is separated using your finger. Then you give a small incision in the rectus sheath and then separate it using two fingers. So you are doing blunt dissection of the sheath. Then going inside, you have to retract the bladder downwards. Okay, peritoneum is also opened using your fingers, both the index fingers. So you are not using the scissor or the knife to dissect the peritoneum also. Then coming to the uterus, in the uterus give a small incision and with your fingers only retract the muscles so that the uterus separates. So everything, all the dissections mostly are done using blunt technique. It is favorable in primigravida where there is no adhesions, but if there are great adhesions present, then you generally have to go for sharp dissection. Okay, so this is preferred because it leads to early recovery of the patient, and also less post-operative pain. Pain is also less in Misgav Ladakh technique. One more incision I would like to tell you is Maillard's incision. Maillard's technique, what do you mean by Maillard's technique? Maillard's technique is muscle cutting incision. M for M. M is muscle cutting incision. So if there is a lot of adhesion in the body, okay, previous one or previous two cesarean section, in that case you might also need to cut the rectus abdominis muscle rather than separating it. If there is no space, baby is not being able to deliver, then sometimes you may need to give incision over the muscle also. So when you cut the muscle, it is called a Maillard's incision technique. So these are the few questions which are generally asked to you all. I hope you have enjoyed this simplifying OBG session. And do let me know if you have any queries by putting your queries in the chat box. Thank you so much.